What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about neuroanatomy. We talked about many neuroreflexes, such as the pupillary light reflex, the corneal blink reflex, the near response or the near reflex. And we also talked about strokes, ischemic and hemorrhagic. We talked about neurological emergencies and much more. Today, we'll focus on Guillain-Barré Syndrome, also known as Acute Inflammatory Demyelinating Polyradiculoneuropathy. Such a beautiful name for an ugly disease. Does this disease cause a motor deficit or a sensory deficit? It could be either one, but in most cases it's motor. Can this disease have autonomic symptoms? Yes, it can, in the forms of tachycardia or bradycardia, or arrhythmia in general, as well as hypertension or hypotension. There are many triggers or precipitating factors that can lead to Guillain-Barré syndrome, and let's talk about this today. Click the like button, click the subscribe button, and let's get started. This is part of my neurology playlist. Please watch these videos in order for maximum understanding and retention. There's a playlist for neurology and another playlist for neuroanatomy. In my previous videos on Duchenne muscular dystrophy and Becker's muscular dystrophy, we talked about neuromuscular diseases, and you need to classify them this way in your head. All of these conditions can lead to muscle weakness. I could have muscle weakness because of a problem in the spinal cord. I could have a muscle weakness because of radiculopathy. Pathy means pathology. Radiculo means this. What's the radical? The radical is the root of the nerve as it exits the spinal cord. So this is radiculopathy. Or it could be in the peripheral nerve itself. We call this peripheral neuropathy if the pathology is here in the peripheral nerve. Or the disease could be in the neuromuscular junction between the nerve and the muscle. Neuromuscular, between the nerve and the muscle. Or the disease could be in the muscle itself, and we have many types of these. There are muscular dystrophies. Some of them are caused by metabolic disorders, so we call them metabolic myopathies, and some of them are caused by congenital diseases. We call them congenital myopathies. Today's topic, which is Guillain-Barré syndrome, is not a congenital myopathy. Guillain-Barré syndrome is not a metabolic myopathy. In fact, you need to rule out any metabolic causes before you can confirm the diagnosis of Guillain-Barré. Guillain-Barré is not a disease in the neuromuscular junction. It is not a disease in the nervous system, whether brain or spinal cord. Then what is Guillain-Barré then? Guillain-Barré is a polyradiculoneuropathy. If you wish to download these dozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. Again, radiculoneuropathy. What does radiculopathy mean? Pathology of the nerve root as it exits the spinal cord. That's the radical. What is peripheral neuropathy then? It's a pathology in the peripheral nerve, just like here. What if I have a muscle disease? It's myopathy. What if I have a disease in the spinal cord itself? It's myelopathy, such as transverse myelitis. Itis means inflammation, and myelo means the core. What core are you talking about? I'm talking about the spinal cord because it's in the core of your vertebral column. Then what is encephalopathy? Encephalopathy is any disease in the brain. Just like myelopathy could refer to any disease in the spinal cord. Inflammation of the meninges is meningitis. The symptoms of meningitis are called meningismus. Inflammation of the brain tissue itself is called encephalitis, but the brain is too big. It is forebrain, midbrain, and hindbrain. What if the problem is in the cerebrum only? The cerebrum of the forebrain. It's called cerebritis. This is inflammation of the cerebrum, not of the medulla, not the cerebellum, just the cerebrum. What if I have a collection of pus with some neutrophils and nasty bacteria? This is called an abscess. It's a ball of gunk. Define gunk. Neutrophils, bacteria, and bacterial debris. All the cytokines that you can imagine and much more. If you wish to see more videos like this in the future, please drop a brain emoji in the comments. If you have watched my video titled Introduction to Neuroanatomy, see my neuroanatomy playlist, you will recall the 10 commandments of neuroanatomy. Commandment number 1, thou shalt draw your line in the sand. between anterior, which is motor, and posterior, which is sensory, between anterior, which is efferent, and posterior, which is afferent. Commandment number 2, thou shalt understand the difference between central nervous system and peripheral nervous system. Commandment number 3, thou shalt understand the distinction between brain and spinal cord, the distinction between cranial and spinal, the distinction between somatic and visceral, meaning autonomic, and the difference between sympathetic and parasympathetic. You shall know the difference between myelinated fibers and unmyelinated fibers. And you should know the differences among nucleus, ganglion, tract, nerve, lemniscus, fasciculus, and much more. Today we are talking about Guillain-Barré. It affects the peripheral nervous system and not the central one, for the most part. Does it affect the brain? No. Does it affect the spinal cord? Also no. How about the root of the spinal nerve? Yes, it's a radiculopathy and a neuropathy. Of cranial nerves or spinal nerves, it could be either. Either of these could be destroyed in Guillain-Barré. Somatic or autonomic, both are gone in Guillain-Barré. Does it affect myelinated fibers or unmyelinated fibers? It only destroys myelinated fibers in the peripheral nervous system, and when you destroy the myelin, these fibers will lose their myelin and become demyelinated. And since normally myelin appears white, and I am causing demyelination, the white fibers will now appear gray if I have Guillain-Barré syndrome. Thou shalt draw your line in the sand is the first commandment of neuroanatomy. Anterior is mostly motor, posterior is mostly sensory. This is efferent, this is afferent. Motor is efferent because it will start here and go somewhere else. So it starts here and goes somewhere else, so we call this efferent. However, sensory is the opposite. It starts somewhere else and reaches the brain, so we call this afferent. Same thing in the spinal cord. You draw your line in the sand. Anterior is motor, posterior is sensory. We have gray matter and we have white matter in the spinal cord. We have ventral root or anterior root, and we have dorsal root or posterior root. Anterior is motor and efferent. Posterior is sensory and afferent. There is a ganglion in the dorsal root, but no ganglion for the ventral root, because this is important for survival. When you are running from a tiger, there is no time to waste relaying in a stupid ganglion. Everything has to be so quick, otherwise you are someone else's lunch. Then, the ventral root and the dorsal root shall unite together to give me a spinal nerve. One on the left and one on the right, of course. And you repeat this 31 times along the spinal cord because you have 31 segments of the spinal cord and therefore 31 pairs of spinal nerves. Then each spinal nerve will divide into anterior primary ramus and posterior primary ramus. Literally no one cares about the posterior primary ramus. This is just for the skin and the muscles of your back, and that's it. But all the actions, all the autonomics, all the cervical plexus, brachial plexus, lumbar plexus, sacral plexus, all of the action happens by the anterior primary rami of your spinal nerves. We are only 7 or 8 minutes into this video, and you have already mastered more neuroanatomy than your professor has ever taught you. Next, central versus peripheral. Central nervous system is brain and spinal cord. That's it. Peripheral nervous system is cranial nerves and spinal nerves. Unfortunately, most students think that cranial nerves are central. That's not true. Just because you are in the skull does not make you central. The definition of central nervous system is brain and spinal cord, period, end of issue. However, anything that comes out of the brain or out of the spinal cord is peripheral nervous system by definition. So the nervous system is central nervous system and peripheral nervous system. Central nervous system, brain and spinal cord, and thank you very much. Peripheral nervous system is cranial nerves and peripheral nerves. So therefore, how many cranial nerves do you have? You have 12 pairs. How many spinal nerves do you have? 31 pairs. All of these nerves are peripheral nervous system except the optic nerve, which is the second cranial nerve. The optic nerve is part of the CNS, not the PNS. And this is the exception to the rule, and it's an amazing exception. If you understand this, you'll understand why multiple sclerosis causes optic neuritis, but Guillain-Barré does not. And you will understand why Guillain-Barré can lead to ophthalmoplegia, but multiple sclerosis usually does not. Why is this? Because multiple sclerosis is demyelination of the central nervous system. So therefore, multiple sclerosis is going to hit me here in my brain, and it's going to hit me in my spinal cord, okay? And of course, since the optic nerve and only the optic nerve is central nervous system, therefore this is affected as well, and I will suffer from optic neuritis, bulbar neuritis, you can call it whatever you want to call it. That's it for multiple sclerosis. Can multiple sclerosis have bladder issues like urinary incontinence? Sure, because the micturition reflex is in the spinal cord and the spinal cord is hit in multiple sclerosis. Contrast that with Guillain-Barré Syndrome. Guillain-Barré is a peripheral demyelination, meaning demyelination of the peripheral nervous system. So Guillain-Barré can affect all of your cranial nerves except the optic nerve. It can affect all of your spinal nerves with no exception. And since cranial nerves 3, 7, 9, and 10 have autonomic function, and your thoracolumbar and sacral segments have some autonomic nerves, therefore we can argue logically that many patients of Guillain-Barré syndrome will suffer autonomic symptoms. And since your heart is as autonomic as it gets, your heart can dance with madness if you have Guillain-Barré syndrome. Next, myelinated versus demyelinated. Myelin appears white in color. So in the spinal cord, on the outside, we have white matter. These are myelinated fibers. But on the inside, we have gray matter. These are demyelinated fibers or just cell bodies. This is a cell body. This is a soma, like this. And by definition, the soma can never be myelinated. If you want to myelinate, you can myelinate the axon. So some axons are myelinated, others are non-myelinated. But all of the somas by definition are unmyelinated. You cannot wrap them with myelin. It ain't gonna happen, baby. Your Schwann cell or oligodendrocyte is gonna yell at you. You want me to myelinate this? I can't. So in the gray matter, we see tons of somas. There are somas here, which are motor because we are in front of the imaginary line. The somas here are sensory because we are behind the imaginary line. As for the somas here, they are autonomic motor because we are in front of the imaginary. So in the spinal cord, myelinated fibers are on the outside and unmyelinated ones are on the inside. Conversely, the brain is the opposite. The unmyelinated gray matter is on the outside, whereas the myelinated white matter is on the inside. Since we have agreed that Guillain-Barré syndrome is a problem in the peripheral nervous system, we have immune disease that's affecting Schwann cells. And when you destroy my Schwann cells, which used to myelinate my nerve fibers in the peripheral nervous system, now I will lose the myelin in the peripheral nervous system. However, the brain will be intact, the spinal cord is intact because both of them are central nervous system. The only myelin that's lost is in the peripheral nervous system, meaning the cranial nerves and the spinal nerves. Next, if you're talking motor, which is efferent, which is in front of the imaginary line, we have two neurons, upper motor neuron, which ends here, and lower motor neuron, which starts here and ends on your muscle, on your skeletal muscle, that is. But when it comes to the sensory stuff, you have three neurons, first order neuron, and then second order neuron, which is gonna hit the thalamus, and third order neuron, which is gonna start in the thalamus and hit the cortex behind the imaginary line, because we're talking sensory now. Does Guillain-Barré affect motor or sensory? The answer is both. When it affects motor, does it affect upper motor neuron or lower motor neuron? Think about it. Guillain-Barré is demyelination of the peripheral nervous system, so only the lower motor neuron is affected. And if you are a neurology buff, because you watched my neuroanatomy playlist, you will recall that the symptoms of a lower motor neuron lesion include hypotonia, hyporeflexia, negative Babinski sign, and flaccid paralysis, and a bunch of fasciculations. These are your 12 cranial nerves. All of them are peripheral nervous system, so therefore Guillain-Barré can destroy all of them, sparing only one, which is the optic nerve. The optic nerve, which is the second cranial nerve, is spared in Guillain-Barré syndrome, but it's hammered in multiple sclerosis, which will be the topic of the next video. Let me give you a beautiful definition of Guillain-Barré syndrome. Every single word here is worth its weight in gold. Guillain-Barré is an acute immune-mediated demyelination of the peripheral nervous system. Okay. Take it step by step. It's acute, which means it's not chronic. It happens quickly. Immune-mediated, caused by the immune system. Demyelinating, I'm losing the myelin. Am I losing the myelin in the peripheral nervous system or in the central nervous system? I'm losing it in the peripheral nervous system, and from the motor aspect, since the peripheral nervous system is lower motor neuron, therefore the patient will have lower motor neuron lesion with hypotonia, hyporeflexia, and negative Babinski sign, causing polyradiculoneuropathy. This word is so beautiful, it's giving me daddy. What does pathy mean? Pathology. What does neuro mean? Peripheral nerve. What does radiculo mean? The nerve root as it exits from the spinal cord. What does poly mean? Many. So we have diseases in many nerves and in many nerve roots. Guillain-Barré has motor symptoms, sensory symptoms, and autonomic symptoms, but predominantly it's a motor deficit disease, usually in the form of acute, flaccid, ascending paralysis. The maximum weakness, the clinical nadir, happens around 4 weeks from the onset of the disease. So if I was normal here, and I started to deteriorate, the maximum deterioration will happen here about 4 weeks from the onset of the disease. Guillain-Barré has many other names. This disease has been called every name in the book, including Guillain-Barré Syndrome, including GBS, including acute flaccid paralysis, including ascending paralysis, and including my favorite, Acute Inflammatory Demyelinating Polyradiculoneuropathy, or AIDP for short. And God only knows how much we appreciate this specific abbreviation in this specific scenario. Try saying Acute Inflammatory Demyelinating Polyradiculopathy every time you meet your family. What's the cause of the disease? We do not know. However, we suspect that this is an infection-induced abnormal immune response. What kind of immune response? Are we talking B cell immunity or T cell immunity? The answer is both. So it's both humoral, which is B cell, and cell-mediated, which is T cell. If you want to know the difference between humoral and cell-mediated, please refer to my immunology playlist. What are we attacking? We are attacking Schwann cells, which is responsible for what? It's responsible for myelinating the peripheral nervous system. So now there is demyelination of the peripheral nervous system, causing a lower motor neuron lesion. What are the triggers? What are the precipitating factors? Viral infections such as Zika and others, bacterial infections, especially Campylobacter jejuni, mycoplasma, and Lyme disease caused by the nasty Borrelia burgdorferi. After surgery, I can develop Guillain-Barré Syndrome, and that's why medicosis will never undergo any surgery unless it is life-saving for a life-threatening condition. I do not undergo surgery to improve my physique or to boost my morale. No, thank you. Guillain-Barré might be waiting in my future. Inoculations can lead to Guillain-Barré syndrome. I mean, think about it. If a certain virus or bacteria can cause Guillain-Barré, then it makes sense that the vaccine that contains a piece of the bacteria or a piece of the virus can trigger the same Guillain-Barré. The only real question is Guillain-Barré more common after the viral infection itself or after the vaccination against that virus? This is the important empirical question. Guillain-Barré can be associated with lymphomas and with systemic lupus erythematosus. Ascending paralysis that starts downstairs and goes up, for example, it started in my feet, and before you know it, it's in my diaphragm. This is called ascending. Other types of paralysis start upstairs and descend like this, so they are descending paralysis. Ascending paralysis examples include Guillain-Barré syndrome, transverse myelitis, which is inflammation of the spinal cord, and tick paralysis. The descending paralysis is botulism caused by the nasty toxin of the nasty bacteria known as Clostridium botulinum, myasthenia gravis, and diphtheria caused by the nasty bacteria Corynebacterium diphtheriae. The clinical picture, i.e. symptoms and signs of Guillain-Barré syndrome. First, what's the difference between symptoms and sign? Symptom has a Y, so you, as a patient, is going to tell me what is going on. However, signs has an I, so I, as a physician or a nurse, is going to discover it by physical exam. Symptoms. The patient complains of weakness, usually in more than one limb. For example, right arm and left arm, or right arm and right leg, or all the limbs. It's usually a symmetric weakness because the nasty immune attack doesn't care. It's going to affect every part of your body. It's not going to say, well, I like the right leg, but the left leg is kind of mid. It's not going to happen because it's a systemic disease and not a localized disease. Is it proximal weakness or distal weakness? It's both. So proximal weakness is something like this. This is my biceps, which is near the shoulder, so that's proximal. Distal will be something like in the hands. Guillain-Barré can do both. If I have problems in the thigh, which is proximal, I'll have difficulty getting up from a chair. I'll have difficulty climbing stairs. If it happens in my biceps or in my arm, I'll have difficulty combing my hair. The paralysis is ascending. It starts downstairs and heads upstairs. Back pain is common. These symptoms are motor, back pain is sensory, paresthesia, which means tingling and numbness, pins and needles, is a sensory deficit, usually in a glove and stock distribution. So wherever you put your glove on or your stock on, you're gonna feel tingling and numbness. Autonomic symptoms can happen, including bradycardia or tachycardia, hypotension or hypertension, and these are autonomic symptoms. Next, as a doctor, you need to check the reflexes. There are two types of reflexes, superficial reflexes and deep reflexes. We're talking about the deep reflexes right now. One of them is the knee-jerk reaction, technically known as the patellar tendon reflex. You tap the patient's knee, the knee will jerk. But in Guillain-Barré Syndrome, the reflex is diminished, sometimes absent. Actually, absent is more common than diminished. Another motor symptom that can happen is respiratory insufficiency, and this can be a cause of death in these patients. That's why doctors should always check the pulmonary functions in these patients. More motor symptoms or signs include weakness of the facial muscles, ophthalmoparesis. Paresis means paralysis or weakness of the eye muscles. This is not the optic nerve. These are oculomotor, trochlear, and abducens nerves, which control the extraocular muscles. Remember that these are peripheral nerves, and therefore they can be affected in patients with Guillain-Barré syndrome. Although not very common, papilledema can happen, and difficulty swallowing can happen as well. Is Guillain-Barré one disease? Nuh-uh. It has many clinical variants. The one that we talked about today is Acute Inflammatory Demyelinating Polyradiculoneuropathy, or AIDP. Another variant is Acute Motor Axonal Neuropathy, or AMAN. There is another called Acute Motor and Sensory Axonal Neuropathy, and this is abbreviated Acute Motor and Sensory Axonal Neuropathy. Miller-Fisher syndrome, acute pan-dysautonomia. This is the autonomic nervous system. It is dysfunctional all over the body. Pan means extended, as in the word panorama, or pancytopenia. How can we diagnose Guillain-Barré syndrome? Lumbar puncture. You can find albuminocytologic dissociation in most patients, but not all. What does albumino mean? It's referring to albumin as a protein. What is cyto? Cyto means cell. What kind of cell are we talking? We're talking about white blood cells, usually the mononuclear leukocytes. In patients with Guillain-Barré syndrome, the albumin is high, but the cells are low, sometimes non-existent. And this is the dissociation. This is the disconnect between the albumin, which is high, and the cells which are low. However, in patients who have HIV that has affected the brain and the spinal cord, or that cause meningitis, we expect the white blood cells to be high and the albumin to be high. Next, besides the lumbar puncture, we can do electromyography and nerve conduction studies. You need to find problems in 2 or more motor nerves before you can confirm the diagnosis of Guillain-Barré. There are many abnormalities that can be seen. This is just 2 examples. Prolonged absence of H reflexes and decreased conduction velocity in these nerves. There is also prolonged distal latency, conduction block, and temporal dispersion. If you want to learn more about EMG, I have a special video on this topic and you can find it in my physiology playlist. Next, we find IgG antibodies against gangliosides, such as ganglioside GQ1b and ganglioside GM1. But we only find these in specific variants, such as Miller-Fisher syndrome and the acute motor axonal neuropathy. But we do not find these specific antibodies in the acute inflammatory demyelinating polyradiculoneuropathy. If everything fails to confirm the diagnosis, you can biopsy the nerve. You will find segmental demyelination in that peripheral nerve, of course, because the Schwann cell is being attacked by T cells and by monocytes/macrophages. So you'll see demyelination and infiltration in these nerves, which proves that this is acute inflammatory immune-mediated demyelinating polyradiculoneuropathy. How can we manage Guillain-Barré syndrome? Non-pharmacological therapy includes to monitor respiratory functions because respiratory insufficiency is common and deadly. Pulmonary toilet is recommended frequently, cardiac monitoring for arrhythmias, frequent repositioning of the patient's body to decrease the risk of decubitus ulcers, and antithrombotic stockings to decrease the risk of thrombosis. Acute treatment includes intravenous immunoglobulin. What's that? This is like throwing a stick to the dog. The dog immune system is gonna be busy attacking the stick that I gave the patient and will forget to attack the Schwann cells. So the immune system will leave the Schwann cells alone. Also, IVIG tends to inhibit macrophages or monocytes. Before you give immunoglobulins to the patient, make sure that the patient does not suffer from selective IgA deficiency, because for these patients, when you give immunoglobulins, some of them are foreign because this patient has never seen IgA before. So the moment you introduce something foreign to the patient's body, the patient will reject it. So before you give IVIG for any patient for any reason, make sure to check serum IgA level and make sure it's normal. Another option is plasma exchange or plasmapheresis. What is pheresis? Apheresis means separation. Does anyone remember electrophoresis? It's the same thing, separation by means of electricity. To learn more about electrophoresis, refer to my biochemistry playlist and my hematology playlist. Why am I doing this? I'm trying to remove the nasty antibodies from the patient's body and replace them with normal plasma. So you remove the patient's plasma and give the patient new plasma, or remove the patient's plasma, clean it up, and return it back to the patient. Ventilatory support is important whether it's an acute treatment or chronic management. Glucocorticoids are not recommended in Guillain-Barré syndrome. They might even slow down the progress that the patient is making. Some pearls for the pros that professors will never tell you. Myasthenia gravis can affect the masseter or the masseter muscle, which helps me chew my food. So many patients with myasthenia will complain of jaw weakness or, doctor, I cannot chew a cracker or a biscuit or some crusty pizza or whatever. However, Guillain-Barré syndrome does not affect the masseter muscle for some reason. Next, something that we have all observed, but we have never wondered why. I want you to go take a shower, a warm shower for 30 minutes. Or, if you do not want to take a shower, just immerse your hands in warm water for 30 minutes. And then take your hands out of the water. You will find that on the palmar surface of your hand, on the palm of your hand, especially on the fingers, they are wrinkled or puckered. However, this is usually not happening on the dorsum or the back of your hand. So why does it happen on the palmar surface of the hand but not the dorsal surface? Ever wondered why? Because the palmar aspect of your hand does not contain sebaceous glands. However, the back of your hand does contain sebaceous glands. Sebaceous glands secrete an oily material, and oil acts as a surfactant, decreasing the surface tension. So there will be less tension on the surface of the back of your hand, so it will not wrinkle as much as the palmar surface of your hand, something that your professor will never tell you. You know this wrinkling that happens after a warm shower? It does not happen in the following patients. Usually you will not see wrinkling on the fingers in patients with Guillain-Barré and in patients with diabetic autonomic neuropathy, median nerve neuropathy, anesthesia, because they paralyze everything, so you will not see wrinkles, post-sympathectomy, and if there's severe edema in the hand, it will not wrinkle. And that's why you should be a good doctor or marry a good doctor, because they will tell you that your diabetes is getting out of control when you get out of the shower without wrinkles in your fingers. Now, of course, do not expect your doctor to know any of this anytime soon. Unfortunately, most doctors today are a bunch of doofuses with a stethoscope. Let's summarize everything that we talked about today about Guillain-Barré syndrome. History. The patient had viral infections or bacterial infections or inoculations or surgery, etc. And then 1 to 4 weeks later, started developing neurological manifestations. The patient can complain of, I cannot get up from a chair or it's becoming difficult. I'm having hard time climbing upstairs. I have difficulty swallowing, etc. On physical exam, there is weakness in more than one limb and areflexia. This sentence is very important. Weakness in more than one extremity plus areflexia should make you suspicious of Guillain-Barré Syndrome. Symmetrical weakness, facial weakness, ascending paralysis, ophthalmoparesis, and respiratory insufficiency, which is deadly. Sensory deficits, paresthesia, tingling and numbness, pins and needles, gloves and stockings, and back pain. Autonomic instability, tachycardia, bradycardia, any arrhythmia, hypotension, hypertension, etc. How do I diagnose Guillain-Barré? Lumbar puncture to look for albuminocytological dissociation, and you do electromyography or nerve conduction studies if you find abnormalities in 2 or more motor nerves. You have your diagnosis of Guillain-Barré. Treatment includes intravenous immunoglobulin and plasma exchange or plasmapheresis. Make sure the lung function is not deteriorating. You provide pulmonary toilet and ventilatory support as needed. At the end of the day, most cases of Guillain-Barré syndrome are not chronic. Most patients show complete recovery. Quiz time. Here are 4 diseases, and I want you to tell me, in each one of them, do we expect the deep tendon reflexes to be absent, diminished, normal, or exaggerated? So I need you to answer this for this disease, this disease, this disease, and this disease. So basically you are matching from this column to that column. So in Guillain-Barré, what's happening to the DTRs? Is it this, this, or this? In Miller fissure, what's happening? Is it this, this, or this? In botulism, what's happening? Is it A, B, or C? Let me know your answer in the comments. You will find the answer key in the next video where we talk about multiple sclerosis. Do you want to learn more about cardiac arrhythmias, angina, myocardial infarction, transient ischemic attack, strokes, ARDS, acute limb ischemia, drowning, the toxidromes, etc.? Download my emergency medicine high yields course at medicosisperfectionalis.com. To learn more about neuropharmacology, such as the anti-epileptics, antidepressants, antipsychotics, anti-Parkinsonian agents, the opioids, the anesthetics, the stimulants, the sedatives, and the hypnotics, download my CNS pharmacology course at medicosisperfectionalis.com. It comes with videos, notes, and cases. If you found these videos to be helpful, please consider supporting my channel by buying me a coffee. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.